What are some ways to support Frank psychologically to help him deal with his decreased abilities? So we would relate increased participation in occupations to quality of life, encourage new routines to promote participation, and identify coping skills and address mental health that could come along with having a new diagnosis. What type of adaptations to the environment or adaptive equipment would you want to use in addressing the safety concerns identified? We would remove the rugs from the home and keep walkways clear to prevent falls, placing items that are used daily within reach and in sight. That is, rearranging commonly used items in the kitchen, bathroom, living room, and bedroom. We'd also encourage use of safe items until judgment improves. So using the microwave versus using the stove, using an electric kettle versus the stovetop. Would Frank be a good candidate for using a tablet or other assistive device to help him resume ADL? Why or why not? Frank's hobbies include outdoor activities as well as home maintenance, so we would focus on these first. Simple technology assistance like setting alarms can be beneficial to addressing safety concerns and completing ADLs. So in that respect, we could use a little bit of assistive devices. Frank uses humor throughout his intervention sessions, especially when he is having a particularly difficult time with something. Why do you think he is always trying to be funny, and how would you deal with it? So Frank makes friends pretty easily. We learned about his wife, his neighbors, and his coworkers, and he seems like a pretty easygoing guy. He probably is using humor as a defense mechanism or even a way to cope with his new reality. As OTs, we can allow Frank to use his humor as part of his recovery. If it gets to be a hindrance or excuse to not participate in therapy, we would redirect him and encourage him to continue participation by facilitating those movements. What concern might Frank have related to his loss of function? His primary concern will be whether or not he'll be able to get back to doing his hobbies independently. He might wonder how long it'll take for him to quote unquote fully recover, and whether or not he can receive outpatient or home therapy after discharge, and what exercises he can be doing on his own.
Would you include Frank's wife in any patient family education? If so, in what areas? We would include her in education due to Frank's cognitive deficits, physical deficits, neglect, and safety concerns. The OT can teach his wife different ADL skills such as dressing and bathing tasks, how to advise Frank on utilizing his left side, educate on safety and activities and transfers since Frank is having balance issues and poor safety awareness, and body mechanics if she helps with his transfers. Using the areas identified in a previous question, how could you go about educating Frank and his wife? The OT would continue to educate Frank on the previously mentioned topics through continual reminders and prompting. For Frank's wife, we would have her sit in the session and watch and ask questions. The OT should let her practice with him in the facility to confirm understanding. Also, the OT should provide handouts regarding techniques such as hemi dressing, exercises when appropriate, and body mechanics. This is a picture that is an example of hemi dressing that you could provide to his wife. How would you work with the team to educate Frank on safety issues? We would first explain the importance of a team approach and consistency with teaching safety to Frank. Using techniques with Frank such as repetition of information, checking for understanding, this could be verbally or through his actions, as well as visual signs to remind him of the safety techniques. What social supports can you identify and how might you incorporate them into your intervention? So as previously mentioned, his social supports are his wife and his friends from the post office. His wife can be incorporated, as we mentioned previously, and the way that we could incorporate his post office friends is when they're visiting, they could motivate and encourage Frank. So they bowl together, so working with Frank on bowling could be very motivating to have a friend with him. What theories or frames of references might you use in developing an intervention plan? Describe the rationale for your choices. So the first one we'll look at is biomechanical. This focuses on body as a machine and strength, endurance, and structural integrity to improve function. With a CVA, you'll be working on these things to get function back to the affected extremities. The OT has already used this frame of reference through completing range of motion manual muscle testing, which are assessments used in the biomechanical approach. We could also use the EHP frame of reference. This is based on performance is improved by establishing or restoring the person's skills or abilities, altering and adapting the context or the task to support performance in context, preventing occupational barriers, or creating enriching occupational performance. This is a great frame of reference for Frank in that the goal is to restore his skill as much as possible, but some aspects of the context or occupation will possibly need adaptation. You can also use MOHO. This uses the motivation for occupation, the routine patterning of occupations, the nature of skilled performance, and the influence of environment on occupations. Frank could use some motivation through preferred activities to keep recovery continuing. Another approach is the rehabilitative approach, and this aim is to increase independence by providing environmental adaptations and compensatory strategies. Consider the client's roles and the tasks the client considers essential for satisfactory performance of these roles. With wanting to go home, it is important to look at the possible environmental adaptations and ways that he may need to compensate. Take into consideration Frank's roles as a husband, a friend, when completing the adaptations and compensatory strategies. What, if any, evidence can you find to support your choice of theory or frame of reference? There was an article regarding best frames of references used specifically for a stroke patient. This article stated that rehabilitative, biomechanical, and MOHO were the top 3 used frequently. This is a link to that article if you are interested. What theory or frame of reference would you use to remediate Frank's neuromusculoskeletal deficits? Why? And can you find evidence to support the use for this intervention? So I used the same article, and that was where the support came from. But for the neurodeficits, we would use more of a behavioral frame of reference. For the musculoskeletal, we would use the biomechanical and rehabilitative frame of reference to address these deficits. All of those were mentioned in that previous article. So this is Frank's problem list. He has a right CVA, he has coronary artery disease, he has diabetes, weakness such as posture, walking, balance, perception, figure ground, left neglect, decreased range of motion and strength, lack of tone, poor safety awareness, cognitive deficits with attention span, insight, judgment, and safety concerns. What are Frank's strengths, and how could these be drawn on during the intervention planning? So some of his strengths include he has some passive range of motions, he's humorous and has a positive personality, has motivators with hobbies such as woodworking, gardening, and bowling, and he has supportive people in his life with his friends and his wife. So we would draw on these to motivate and encourage him to continue to work, as well as utilize the abilities he has to build off of his current skills. Identify at least 2 functional assessments to evaluate Frank's lower extremity and upper extremity use. Why did you choose them, and what information will they provide to assist in intervention planning? So I chose the NIH Stroke Scale Assessment, and it specifically goes into each possible symptom in relation to a stroke and tests how severe things like motor arm, motor leg, sensory, language, etc. can be. This is on a 3-point scale, and it has the top one being a normal and the end one being a major deficit, with the middle being a medium. You could also use the motor assessment scale, and this is used to assess everyday motor function in stroke patients. Frank struggles with ADL and mobility, and this would directly look at both of these functions through the assessment. These 2 are ones that we have reviewed in a previous stroke unit, and I think would be helpful for Frank to complete. What would be the long-term goals given what you know about Frank and what his wife wants? How would you incorporate Frank's wishes into your intervention planning? So we would create goals based off of some things that need to be looked at, as well as something that he maybe wants to do that's more hobby related. So here are 3 goals. By the end of week 3, patient will independently demonstrate safety awareness using scanning techniques during ambulation. By the end of week 3, patient will perform upper body dressing with setup. And by the end of week 3, patient will independently engage in bowling using his Hemi walker. And we used a 3-week scale because he is estimated to be in rehab for 3 weeks. So some of the short-term goals for Frank would be by the end of week 1, patient will demonstrate scanning techniques with minimal verbal prompting. By the end of week 1, patient will perform upper extremity dressing with moderate assistance. And by the end of week 1, patient will engage in upper extremity strengthening activities in order to bowl. If you think that Frank and his wife have unrealistic long-term goals for his rehab stay, how would you handle this? We would handle this by having an open conversation regarding what the projected returns will be so that they have clear information about his diagnoses. We would also discuss modifications or adaptations that could be implemented to help achieve the goals Frank and his wife have that may or may not be applicable without modifications. What obstacles do you see Frank reaching his stated goal? Although Frank masks his frustration with humor, it is still frustration. This can be a barrier to his progress if the joking is a distraction during therapy session. As the OT, it is imperative that all therapeutic activities meet the just right challenge for Frank.
What role would a CODA play in Frank's assessment and intervention? Be specific in terms of skills during evaluation, intervention planning, and intervention sessions. So the CODA can't complete the evaluation or planning for the intervention. They can provide information to the OTR regarding what was seen during the session. The CODA can carry out the intervention session with the OTR direction and treatment plan implemented. Any observations, adjustments to the plan, improvements, or deteriorations should be brought to the OTR. Are there other standardized assessments that you would administer? For what areas? Why did you select the assessments, and what information would you hope to gain from them? We would use the stroke-specific quality of life scale, the assessment of motor and process skills, and the Sames-Weinstein monofilament test. These assessments would assess his quality of life post-stroke and his motor and cognitive abilities. Because he shows signs of frustration and quality of life, a quality of life assessment may shine more light on what internal problems Frank is facing. A more specific assessment for motor and processing skills would assist us in understanding how to better help him address the areas of difficulty. The monofilament test would help us better assess his sensation. Did you choose assessments at the client factor's body function level or participation level, or were they occupation-based? Find an assessment that targets a different level of body function, participation, and occupation. We chose assessments at the client factor's body function level. These are the stroke-specific quality of life scale, the assessment of motor and processing skills, and the Sames-Weinstein's monofilament test, as well as the motor assessment scale and the NIH stroke scale, which are all about function and quality of life of the person. A good assessment would be at the occupation level would be the CATS Index of Independence and Activities of Daily Living. Frank has regained active range of motion in 15 degrees in all motions of his upper extremity. How would the intervention plan be modified? How would this affect his ability to use his upper extremity functionally during ADLs and other activities? The intervention plan would not change. The increase in active range of motion would just allow for grading up activities in order to continue the remediation process. This would continue until Frank reaches a functional range or does not have any more return and adaptations need to be implemented. Active range of motion would increase his function in all ADL and other activities being performed.